Well, greetings everyone, and welcome to the EKG case for the week of January 29th, 2012. Got a nice, relatively simple case for you. This is a patient that we recently saw. A 60-year-old man presented to the emergency department complaining of an asthma exacerbation. And there's no trick questions here. He came in complaining of his typical asthma, and he wasn't ready to be intubated. He had a lot of wheezing. But the one abnormality that stood out was he was very tachycardic. His heart rate was varying anywhere from 140s to 160s on the monitor, a little bit too much. He had not been on continuous nebulizers or anything unusual like that, so we were obviously concerned. And what's the first test you got to do? Of course, an EKG. Get an EKG on this guy. And here's the 12-lead EKG. And what you notice is that it is irregular. Now, if you're paying attention last week, hopefully when you see something that's irregular, you've really gotten paranoid about it and you've gotten your calipers out and you're marching these things out just to make sure that it truly is irregularly irregular, because if it's regularly irregular, then you're going to be thinking about PACs or you're going to be thinking about MOBITs. And when you map this one out, it actually is irregularly irregular. So the machine helps you out here because the machine calls this atrial fibrillation. Now, what do you do for atrial fibrillation? This is new onset atrial fibrillation. Last week we talked about a computer read that said new onset atrial fibrillation, and it was wrong. And it resulted in unnecessary anticoagulation and some near disastrous results. Well, here the computer is telling you once again it's atrial fibrillation. You've always got to be careful when the computer tells you that something is atrial fibrillation, because as we mentioned last week, atrial fibrillation is the most commonly overdiagnosed incorrect dysrhythmia. And so you take a really close look at it. And the purpose of this week's case is to simply talk about a differential once again. The differential of irregularly irregular tachycardia. The computer always thinks of AFib, but there's two other things you got to think about. It's kind of nice to have a differential of only three things, and that's why I think dysrhythmias are really easy. Because when you see an irregularly irregular tachycardia, there's only three things you've got to think about: AFib, atrial flutter with variable conduction, and multifocal atrial tachycardia. Only three things. How easy can it be, right? So, when you see irregularly irregular tachycardia, how do you know which of these three things is going on? Very simple. You ask, what is the atrium doing? What are those darn P waves doing? If somebody's got atrial fibrillation, what the atrium is doing is very irregular. You see no clear-cut regular atrial activity. You just see the squiggly line, or if it's new onset afibrillation, sometimes you see this type of rhythm where there's a lot of bumpiness, and that's referred to as coarse AFib. And if somebody went into AFib for the very first time, that's probably what you see. And then the longer they stay in AFib, the more it starts evening out. All right, so you start out with coarse AFib, and oftentimes this bumpiness can be misdiagnosed as atrial flutter. But if you map out these bumps, they really don't map out regularly. And so, that's irregularly irregular, bumpy atrial activity, and that's referred to as atrial fibrillation. Okay, what's the next possibility? A flutter with variable conduction. You're accustomed to seeing A flutter with 2-to-1 conduction, and so normally A flutter is regular, but atrial flutter can sometimes have variable conduction, and what that means is that in some parts of the EKG it can be 2-to-1, in some parts it's 3-to-1, in some parts it's 4-to-1, then it goes to 2-to-1, then 4-to-1, then 3-to-1. It's all over the map. And so when atrial flutter has variable conduction, the overall ventricular response can be irregularly irregular. So A flutter can be irregularly irregular. How do you know you're dealing with A flutter? Well, you'll see fairly regular, clear, regular atrial activity, and those flutter waves, P waves, flutter waves, will map out at a rate generally of about 300 beats per minute. Okay, so just to recap, AFib, no clear regular atrial activity. Atrial flutter, you do see regular atrial activity, and if you map those out, they do map out regularly. And the third possibility for an irregularly irregular tachycardia is multifocal atrial tachycardia, MAT. This usually occurs in pulmonary patients, theophylline toxicity, COPD, bad asthma, pulmonary hypertension, people with some type of lung stuff going on. And as you recall, this patient did have an acute asthma exacerbation. What do you see with multifocal atrial activity, or MAT? You see clear-cut atrial activity, but it's irregular. So you'll see nice P waves, but they'll be irregular, and they'll also change morphology. You have to see at least 3 different morphologies for P waves in order to call something multifocal atrial activity. So let's go back to that EKG. And when you look down here at the rhythm strip, okay, what do you notice with the rhythm strip? Well, I see there's a P wave right there, and there's a P wave, and those kind of look a little bit different. And then that's definitely a different looking P wave. Heck, it's irregular, and then there's something there, and then there's another upside down P wave. This one kind of looks like this one, so that's one type of morphology. I think that there's one morphology, there's another morphology, there is another morphology. There's at least 3 different morphologies. You know what? Make it 4. There's another morphology there. So there's at least 4 different morphologies for P waves. But the key thing is you do indeed see clear-cut P waves which are occurring irregularly. And clear-cut irregular P waves, that equals multifocal atrial activity. So this is MAT. This is your classic MAT. And we still see it often in our pulmonary hypertension patients. Well, maybe not that often, but we see it not uncommonly. How's that? Not uncommonly in our pulmonary hypertension patients and asthma patients. It's not too much theophylline toxicity around anymore, but you will see MAT, and the last thing you want to do is to misdiagnose this the way the computer did as AFib and unnecessarily anticoagulate a patient. How do you treat these cases? Well, AFib, you can shock them, all right? There's my little shock, okay? That's electricity going into the patient if they're unstable. If they're stable, give them an AV nodal blocker like calcium channel blocker or beta blocker. All right? What about atrial flutter with variable conduction? If they're unstable, you can zap them. There's that electricity again. A flutter is really, really easy to shock. Heck, if you just rub your feet on carpet and shock the patient, they'll convert. So flutter is really, really easy to cardiovert electrically. But if they're stable, you want to be gentle. Give them a AV nodal blocker, calcium channel blocker, beta blocker, just like atrial fibrillation. How do you treat MAT? Do you shock these patients? Absolutely not. You don't shock MAT patients, okay? There are 2 dysrhythmias that you never shock: MAT and sinus tachycardia, because all you do is you make the patient really angry. It doesn't solve the rhythm, okay? So when you have MAT, how do you treat MAT? And it doesn't matter what the patient's blood pressure is. They can have a blood pressure of 60 with rapid MAT, and shocking the patient is not going to help that blood pressure. What you got to do is treat the underlying rhythm. Heck, give them fluids, treat their sepsis, figure out what's causing the hypotension. But MAT in and of itself does not cause hypotension, just like sinus tachycardia does not cause hypotension. Okay, so when you see MAT, you treat the underlying problem. What that means is that when patients have MAT, figure out what's causing their pulmonary process. In this particular case, the patient's got an acute asthma exacerbation. Treat the asthma, give them steroids, give them albuterol, give them Atrovent nebulizers. If the patient's got COPD, same thing. If the patient's got pulmonary hypertension, if the patient's got pneumonia, you're going to treat the pneumonia. That's how you treat MAT. You treat the underlying cause. You never shock MAT. All it does is make the patient really angry. Sometimes people ask about, well, what about AV nodal blockers? Should I give beta blockers to this patient? No. It's a pulmonary patient. Don't give beta blockers to these pulmonary patients. What about calcium channel blocker? Probably not necessary either. If you really, really want to use a medication on these patients, just give them a little magnesium. If for no other reason, simply because a lot of pulmonary patients have some mild benefit from magnesium. But you know what? Let's not even talk about medications. The treatment of choice for MAT is to simply treat the underlying cause. You do not shock MAT. And once again, don't forget the differential for irregular tachycardias. There's only three things you need to worry about: AFib, A flutter with variable conduction, and MAT. How do you tell the difference between those three? Very, very simple. All you've got to do is to ask yourself, what is the atrium doing? And you'll have your answer. Hope that was helpful to you, and I will talk to you next week. Take care.